Sit in your chair so we can proceed to this session. We are already late, 5 minutes, waiting for other colleagues to come after tea. Today's session is about adrenal. Before starting the presentation and inviting my speaker to the stage, I would like to invite the chairperson before the chairperson. The first chairperson is Dr. Amna Riaz. She is consultant endocrinologist in Gulab Devi Teaching Hospital, Lahore. The second chairperson is Usman Musharraf. He is a consultant endocrinologist in Elite Hospital, Faisalabad. The third chairperson is Sarwar Malik. He is a consultant endocrinologist in Capital Hospital, Islamabad, CDA. First speaker of this session is Dr. Khurshid Ahmed Khan. Professor Dr. Khurshid Ahmed Khan is the Professor of Medicine in Endocrinology. He is the ex-president of Pakistan Endocrine Society. He kindly come to the stage and take your presentation. Thank
you. Thank you very much for inviting me for this session as a speaker. And the topic we're going to discover is, can I have display of my presentation, please? And the laser, if I can have one, please. So this is the expanding the spectrum of primary aldosteronism. Okay. And I will tell you in later slides why we added the word expansion of primary aldosteronism in our patients. Let's start off with a case. 45-year-old female presented to endo-PD for uncontrolled blood pressure, completely asymptomatic. No significant past medical history except for blood pressure for past 12 months. Currently, she's on amlodipine, valsartan, hydrochlorothiazide, and doxazosin. Blood pressure is not under control. It's 160 by 100. BMI is 25. Physical exam was normal. So, what are the possibilities? Kya possibilities aap samajhte hain? At this stage, everything is possible. Any kind of reason, can we, based on these agents, can we say that she has resistant hypertension? Likely she has resistant hypertension, so there could be underlying reasons for that. But she came to me with these labs. When she came to endo clinic, she had all these labs done. Potassium was 3.7, creat was 0.9, bicarb 23, TSH 2.18, aldosterone level was 27.6, plasma direct renin was 2.1. Metanephrines, normetanephrines, dopamine all normal, urine-free cortisol normal, renal arterial Doppler normal, MRI abdomen and pelvis all normal. So she had all the workup. Someone saw her before me and thought, yes, resistant hypertension, let's work up this patient, and then send this patient to endocrinologist. So where do we go? By the way, let me ask my audience, what do you think are the possibilities? Based on this lab data, now can we tell if there's anything abnormal? Any volunteers?
Thank you very much. In my opinion, now it is sometimes common until we increase the doses of one antihypertensive drug to the high level and then we go to the next. Sometimes we see some prescriptions that we need 5 milligrams of aldosteronism, 18 milligrams of valsartan, or maybe 25 milligrams hydrochlorothiazide would not be enough that we can make a judgment. Anytime if we want to see a good result, we have to go all to the high dosages, and then we can discuss about
Yeah.
that.
Well, thank you very much. You can have a seat. So that's a valid point. These patients should not be on tiny dose of the medications they are on, and should be on therapeutic doses, which she was on. So based on this, what I see in this slide here is the aldosterone levels 27.6, which kind of stands out from rest of the labs. Plasma direct renin is 2.1. So my suspicion, I would tell you, when I saw this patient, I thought, yeah, there's a good possibility this has primary aldosteronism, and we will go through those slides later on during this presentation to see if this patient falls in that diagnostic criteria for that or not. So the bigger question for me is, where do we go from here? Should I do the same? If I'm suspecting primary aldosteronism, should I do the saline loading test on this patient? Should I go ahead, skip this one, and go directly to the bilateral adrenal vein sampling, or I should use other options? How many of you think we should go with the option 1? And raise your hands so I can see that. And option 2? Okay, there are more. So there are more votes for going directly for the bilateral adrenal vein sampling and skipping the saline loading on this patient based on these previous labs of aldosterone 27 and 2.1 of direct renin. So what I did was, she was taking ARBs and hydrochlorothiazide. I took this patient off these two medications. And I said, let's repeat these levels and see what comes up. So I repeated these levels, and aldosterone came out to be 44.9, and plasma direct renin was 0.83. So at that point, I said, okay, well, it's definitely a case of primary aldosteronism. At least it's case detection, so let's go for the confirmation. So at this point, to me, it's a confirmed case. Let's go for the location where aldosterone is being produced. So that's what was my take on this patient. So just to highlight, the first case of primary aldosteronism was reported back in 1954 at CSCR conference. And that time, that patient presented with all the extreme symptoms. That was reported by Dr. Khan during that conference. 34-year-old female during the ward rounds found to have periodic paralysis, intermittent muscular weakness, episodic tetanic manifestations, polyuria, polydipsia, hypokalemia, hyponatremia, alkalosis, hypertension, and ward notes suggesting hyperventilation tetany. So this was the kind of medicine we had back in 54, when some smart physician came on board and said, well, there's something more than hyperventilation tetany in that patient. So this patient had all the possibilities which patients with primary aldosteronism can have. So this results from autonomous secretion of aldosterone from adrenal cortex, and is usually characterized by hypertension, suppressed plasma renin activity, and increased aldosterone secretions. The two most common causes of hyperaldosteronism are adenoma, aldosterone producing adenoma, APA, about 30 to 40%, and the biggest chunk is by bilateral idiopathic hyperaldosteronism. The primary adrenal carcinomatous hyperaldosteronism and familial could be there, but those are relatively rare. Prevalence. Previously, when I was a medical student, we learned, okay, endocrine causes could be this much out of this. Primary aldosterone was about 1 to 2%. But this was based on all the previous studies, because back somewhere around in the late 90s and early 2000s, the endocrinologists started to use this test as a screening tool. Plasma aldosterone concentration to plasma renin activity, which is aldosterone to renin ratio, as a screening test. So since that screening test, we have seen quite a few patients which were previously undiagnosed. We have found that they have actually hyperaldosteronism at the cause. So the application of this strategy led to greater number of hypertensives, led to 5 to 15-fold increase in identification of patients. So what we believe, honestly, at this time, the incidence of hyperaldosteronism is somewhere between 5 to 10. Maybe on the conservative side, if you want to stay, maybe 5 centers who are seeing more patients with more hypertension, more resistant hypertension, their reporting numbers may be 10%. So it's somewhere in this figure. So what that means is, in your practice, if you have seen 100 patients and you have not diagnosed at least 4 or 5 of them to be with hyperaldosteronism, maybe there's underdiagnosis. And I will show you the biggest data on this in coming slides. This is just for the fellows to show how aldosterone is regulated by the juxtaglomerular cells of the kidney. In response to decreased blood pressure, renin-angiotensin-aldosterone in the system is activated. And by increased potassium in the extracellular fluid, you get secretion, adrenal cortex produces increased aldosterone. So these two mechanisms are primarily responsible for production of aldosterone. ACTH may play a role of about 5 to 10% of aldosterone production, but not more than that. So the diagnostic algorithm is case detection. Case detection, earlier I said that test, which is a standard now, aldosterone to renin ratio, that is used as a case detection test. And then comes the confirmation test. So we'll go through those in coming slides. But the bigger question is, who should we screen for hyperaldosteronism? Anyone in your clinic who's presenting with high blood pressure and hypokalemia without any clear reason should be screened for that. Resistant hypertensions. And these means the patients who are on 3 drugs and one of them is a diuretics and still have poor control of blood pressure, they should be screened. Someone had CT done for abdominal pain, and we found out renal incidentalloma in patient, and patient has hypertension also. So that patient should be screened. If patient has hypertension at a young age, less than 30 years of age, should be screened. Or severe hypertension where diastolic is exceeding more than 100, systolic is going above 150, 160, those patients should be considered. And anywhere where you see patient is syndromic and some secondary cause of hypertension is there, those patients. So these are the 6 indications where we want to do the screening test. And the screening test, earlier I said, is primarily, this is the aldosterone concentration and renin activity or renin concentration. So based on that, if the aldosterone concentration is more than 10, that's a suspicious in a patient with hypertension. That should raise your flag that means this patient has possibility of hyperaldosteronism. So in this group, if the patient has spontaneous hypokalemia and plasma aldosterone concentration of more than 20, that's confirmed case of hyperaldosteronism. Meaning thereby, in this patient, you don't need to go for any further confirmation. You rather need to look for the etiology, if this is adenoma or this is adrenal hyperplasia, and you go for further testing. But confirmation is not needed in this group of patients with plasma aldosterone concentration of more than 20, plasma renin to aldosterone to renin ratio of more than 20, and aldosterone concentration more than 20. So that's the primary aldosteronism. You look for the cause for aldosteronism in this patient. But if the numbers are lower than that, then we do need to go for confirmation of the test. In this patient, what I presented to you, the aldosterone was like 47 when I took this patient off those drugs. Renin was like 0.9. So obviously, that's a confirmed case. But had the numbers not been that high, in that cases, the confirmation testing has to be done, and we will come to in coming slides how confirmation should be done. And in a patient with plasma aldosterone concentration less than 10 and plasma renin ratio of more than 1, patient possibly does not have hyperaldosteronism, or even if it's a borderline case, it's not amenable to surgery, so no need to further work up on that patient. So the biggest question for most of the physicians is when they are seeing a patient or when they're thinking that patient has hyperaldosteronism is what drugs are causing false positive or false negative in this patient. So I think this is an important slide for all of you know. Mineralocorticoid receptor antagonist, spironolactone, Plerinone can definitely impact it. ACE and ARBs, they increase the plasma renin concentration, thus they decrease this ratio. So this can give you false negative. Beta blockers, on the other hand, they lower the plasma renin concentration and increase the, and that ratio can be spuriously increased. So beta blocker will give you false positive. So just to be, for you guys to be aware of all these pitfalls, which we can see with primary aldosteronism for patients who are on those drugs. So what drugs ideally these patients should be on before we can say, okay, these drugs have no impact on the patient aldosterone or renin levels. So these are the safer bets: the verapamil, sustained slow release, hydralazine, prazosin, alpha adrenergic blocker, doxazosin, trazosine. So alpha adrenergic blockers, vasodilators, and non-dihydropyridine slow release antagonist, they use calcium channel antagonists. They are usually the drugs which are safer. They do not interfere with any of these ratios. So ideally, these patients should be on that. So once we detect the case, the next step comes the confirmation. And earlier we went through that. In a patient where you can see spontaneous hypokalemia and the ratio of more than 20, then in that particular patient, you do not need to do any confirmation test. There's an exception to that. And exception is if the ratio is more than 30 and you do not have hypokalemia, then even in this case, there are a lot of studies to show the sensitivity and specificity is above 90%. So in this group also, you don't need to do any confirmation test. But all the rest of the groups, you need to do the confirmation with either oral sodium salt loading testing or intravenous saline infusion test. The salt loading is usually very briefly, high dose sodium is given to patient for 3 days. Goal is to sodium intake of 5,000 milligram, which is equivalent to 12.8 grams of sodium chloride. So 24-hour urine sodium is measured on the 3rd day on these patients is collected for aldosterone, sodium, and creatinine. So urinary aldosterone should not be more than 12 microgram in 24 hours. If it is, then that patient is consistent with primary aldosteronism. That case is confirmed. Usually, I would tell you that this is a cumbersome test, difficult test to do, takes long time, needs a lot of coordination. The one easy shortcut is the intravenous saline infusion. But you have to be careful. You're giving this patient 2 liters of saline over 4 hours, but you have to monitor blood pressure carefully. These patients are already, they already have uncontrolled blood pressure, and so we do not want to throw these patients into hypertensive emergency or urgency. So that word of caution has to be there with those patients. So after completion of 2 liters over 4 hours, aldosterone is measured. In normal patients, aldosterone should be suppressed down to less than 5. If it's more than 10, that's diagnostic of primary aldosteronism. Between 5 to 9, these are the, again, gray zones, intermediate. But if the clinical scenario fits well, then you can go for the next step, which is subtype classification. Because aldosterone is being produced from adrenals, so there are multiple conditions. Like I said, gave you at least 4 different conditions which can cause hyperaldosteronism. Adenoma is one of them, hyperplasia is another one, familial syndromes are another one. So all these patients, and carcinoma is another one which can do this. So the best test for these patients is the CT of adrenals. MRI can be done, is fine, but usually CT is the preferred modality for diagnosis of further subtype classification. So adrenal CT should be the initial study to determine the subtype, adenoma versus hyperplasia, and exclude adrenal carcinoma. So in a patient, when a solitary hypodense unilateral macroadenoma more than 1 centimeter and less than 2 centimeter with a normal contralateral adrenal morphology are found in a younger patient, less than 35, with vigorous primary aldosteronism, that usually confirms that this patient has aldosterone-producing adenoma and you can go directly to surgery. The reason that cutoff of 35 is because after 35, many patients can have incidentalomas. Excuse me, I'm sorry. I thought I had this on silence. My apologies. So after 35, patients can have incidentalomas which may not be producing any hyperaldosteronism, causing any hyperaldosteronism. Rather, the problem may be just the hyperplasia. So that's why you have to be careful. Less than 35, you see adenoma in a patient which is a unilateral, more than 1 centimeter, that patient can go for surgery. After this test, no further testing is needed. But if on CT you see adrenal thickening or micronodular changes which suggest adrenal hyperplasia, patients with hyperplasia may even have normal appearing adrenals on CT. So if you suspect hyperaldosteronism and CT shows either adrenal hyperplasia, normal looking adrenals, then the next step usually in these patients is adrenal vein sampling to see if one adrenal is producing more aldosterone compared with the other second adrenal gland. Adrenal carcinoma, if the CT is shows mass more than 4 centimeter with a Hounsfield unit more than 10, likely patient has adrenal carcinoma under the given scenarios. So adrenal CT is done, normal micronodularity or bilateral masses, we go and we think this patient is confirmed case of aldosteronism, hyperaldosteronism, we go for adrenal vein sampling. And adrenal vein sampling lateralizes to left versus the right, then we go for surgery for that side of the gland. On the other hand, CT of the adrenals, unilateral, hypodense mass, more than 1 centimeter, less than 2 centimeter, less than 35, go straight to surgery. More than 35, now we still need to confirm if this is just a non-functional nodule and maybe the other gland has hyperplasia, because after 35, we tend to see a lot more nodularity in adrenals. So that's where we still need to go to adrenal vein sampling. Yes, if it lateralizes to the side where the nodule is, then do go for surgery in that particular patient. Just to show, I think this bottom part is most important. I'm going to skip this, how it is done, but rather this is for you to interpret results. Most patients with a unilateral source of aldosterone will have cortisol-corrected aldosterone lateralization ratio greater than 4. And the ratio greater than 3 but less than 4 represents a zone of overlap, but ratio less than 3 is definitely consistent with no lateralization. That means patient has bilateral adrenal hyperplasia if it's already confirmed case of primary hyperaldosteronism. Aldosterone producing adenoma gets confirmed. Our patient, we find primary adrenal hyperplasia of one-sided gland. Obviously, we all know the treatment is a surgical resection of that adenoma or surgical resection of that hyperplastic single adrenal gland, and that does help the overall situation. The average long-term cure rates of hypertension after surgery is about 30 to 60%, roughly taking 1 to 3 months in resolution. To decrease the surgical risk, hypokalemia should be corrected with potassium supplements, spironolactone preoperatively, but should be discontinued once these patients have operation. Some of them can drop their blood pressure precipitously, so you have to be cautious, you have to be careful post-op in these patients. Follow-up on those patients, plasma aldosterone should be measured 1 to 2 days post-operatively to confirm the biochemical cure. Serum potassium levels should be measured weekly for 4 weeks post-surgery in these patients. In patients with idiopathic hyperaldosteronism, which is hyperplasia of both glands, mineralocorticoid receptor antagonist should be used rather in these patients. Then there are familial types. I'm going to skip those because it's going to take a lot more to get into the diagnostics of each familial type. For you guys, it's only, there are 3 familial types, 1, 2, and 3. 1 we usually call the glucocorticoid remediable aldosteronism. Type 2 is which is indistinguishable from patients with aldosterone producing adenoma or adrenal hyperplasia. And type 3 is when there's a defect in the calcium channel, in the defect in the potassium channel in the distal tubules of the kidney. So that's the type 3. Anyone with primary aldosteronism, this is a very busy table. I'm not going to take you through this table, but anyone with primary aldosteronism and family history of hyperaldosteronism should be screened for and should be tested for familial possibilities, and first-degree relatives of these patients should be tested as well. But remember I told you that we are not screening enough patients. The data which I showed you, and these newer screening test was implemented by the guidelines around 2002 or 2001, around that time, where I said aldosterone to renin ratio. Despite that, this clinical data indicate that testing for primary hyperaldosteronism is performed in only about 2 to 4% of patients meeting criteria for case detection testing. And that data is not from Pakistan. This data was presented by Cohen and Associates, was published in 2021, here this was in Annals of Internal Medicine where it was published. This was a retrospective multi-center cohort study of 269,000 United States veterans जो VA hospitals America में हैं, वहाँ पे जो patients आते हैं with apparent treatment-resistant hypertensions. Out of those patients, so the data they pulled out, they found out these patients on 4 or 5 different drugs and on maximum dose of these drugs, and no one has worked up these patients for aldosteronism. Only 2 to 4% of these patients were worked up. So total of 4,277 patients underwent the recommended testing, and the low testing was observed at all centers and no improvement in testing frequency seen over the 17 years of study. They went retrospectively from 2017 back towards 2000. So it's still, we are not, there are a lot of our patients who do have primary hyperaldosteronism, and we are not diagnosing them. And if we're not diagnosing them, we are not treating them. There was another study which was published back in, I believe, 2020, I would say that was a timeline, by Dr. Young from Cleveland Clinic. And so in that, they found out the average time what it takes for a patient with primary aldosteronism to be diagnosed from the time of presentation is about 4 to 5 years. So patients go from one doctor to the other doctor to the other doctor, or maybe one same doctor is seeing that. But even those numbers, limited number of patients who are being diagnosed with these conditions, they do get diagnosed with a 4 to 5 years of delay. So that's something for you guys to ponder on. And I will tell you that there's data to show even with the hypertension that we believe there's some degree of aldosteronism present. It's a whole spectrum. There tends to be, if patient has stage 2 hypertension, the numbers could be in those patients, these patients have higher level of aldosterone compared with the general population. Yeah, they may not fit the definitions of those ratios and those numbers, but we believe it's a continuum of spectrum where patients with mild hypertension have mild degree of aldosterone production, and with a higher level, they have higher level of aldosterone production. And recently, a few studies have been published on that as well. So important, I think the take-home message, this is my last slide. For you, the take-home message is any patient who I gave you those 6 definitions, but you can be very simple. If the patient is on 3 or more drugs and still uncontrolled, send aldosterone and renal level. In Pakistan, problem is the plasma renin activity is not available. I don't know, in Aga Khan, do you have activity? Concentration. So here's my take on concentration. If you look at all the data, renin activity versus the concentration. Concentration gives you, renin activity gives you accurate measure of what renin is doing. Concentration can give you a false high level for a low renin activity. So as a matter of fact, you're still going to miss few cases. It's still going to make some of your cases go false negative. But the patient you're going to detect based on plasma renin concentration and aldosterone ratio, those patients, they are going to be strong positive patients. In those, there's a high chance of confirmation. So that's the take-home message I would want you to take from this talk. Thank you very much.